Welcome to Module 3 of VPM. In this module, we're going to look at the pharmacology of drugs used to treat psychosis. It's currently the case that all drugs in use today in the treatment of psychosis, such as schizophrenia and mania, are receptor-acting drugs that act to diminish dopamine neurotransmitter function through blocking the dopamine D2 receptor. This picture shows the simplest example of this, amisulpride. The filled pink circle shows that this drug acts solely as a dopamine D2 blocker. This leads to its therapeutic activity, but also to adverse effects such as extrapyramidal symptoms and elevations in prolactin. Chronic blockade of the dopamine D2 receptors can also result in tardive dyskinesia. In the next diagram, we see haloperidol. As well as being a dopamine D2 receptor blocker, the filled blue noradrenaline circle tells us this is an antagonist at the noradrenaline alpha-1 receptor. The affinity of haloperidol for this receptor is lower than that of the dopamine receptor because the noradrenaline symbol is beneath that of the dopamine symbol. Also, note that the connection between the noradrenaline receptor and the drug is a dotted line, not a solid line. And the dotted line tells us that this interaction is not relevant to the therapeutic value of haloperidol, but when haloperidol is given in high doses, this effect becomes relevant in terms of adverse effects, particularly low blood pressure. This is the reason why the IV route is no longer recommended for haloperidol in the production of acute sedation for agitated patients. The next diagram shows aripiprazole. This is also a dopamine receptor acting drug, but rather than being an antagonist, it's a partial agonist. This is indicated by the half-filled pink circle. This means that in states of high dopamine activity, aripiprazole can act as an antagonist and bring down dopaminergic stimulation. But even if all the receptors in the brain are occupied by aripiprazole, the intrinsic partial agonist activity will maintain sufficient dopamine neurotransmission to allow normal motor function, which explains why aripiprazole has a low incidence of Parkinsonism, although it can cause akathisia through reasons we don't yet fully understand. In contrast, when dopamine levels in the brain are low, the partial agonist activity of aripiprazole can enhance dopamine neurotransmission. This is thought to be useful in helping remedy the cortical cognitive dysfunction that is often seen in cases of schizophrenia. Aripiprazole is unique amongst drugs for psychosis in that it does not elevate plasma prolactin. In fact, it can lower it. And the reason for that is because it's a partial agonist, and the stimulation of the dopamine D2 receptors lowers the release of prolactin. You can see from the diagram that aripiprazole also has activity at serotonin receptors, but these are of lower affinity than its activity at the dopamine receptor, and they may add to its therapeutic actions, although that's still somewhat uncertain. Now, in the next diagram, we go back to the very first drug to show efficacy in psychosis, which is chlorpromazine. This was discovered by serendipity in the 1950s, and about a decade later, it was discovered that its mode of action was the blockade of dopamine D2 receptors. Much later, an interaction at the 5-HT2 receptor, where it's also a blocker, was discovered. And this 5-HT2 antagonism probably contributes to its therapeutic activity. But chlorpromazine also acts on many other receptors, and it has some slight activity as a noradrenaline reuptake blocker, although this doesn't seem to be relevant to its antipsychotic action. The other receptor interactions of chlorpromazine explain the very high adverse effect burden of this medicine. For example, histamine H1 blockade leads to sedation and weight gain, and the alpha-1 noradrenaline receptor blockade can result in low blood pressure. The cholinergic muscarinic M1 to M4 receptor blockade can lead to constipation, dry mouth, and cardiac toxicity, particularly in overdose. Another older drug for psychosis is clozapine, and the diagram here shows this has very many receptor interactions, which explain the high incidence of adverse effects. But it may also explain why it can work in some patients where other drugs have failed. Note the relatively low affinity for the dopamine D2 receptor compared with the affinity at the other receptors it acts on. This means that at the dose of clozapine necessary to get sufficient dopamine receptor blockade for the therapeutic effects, all these other receptor actions will be inevitably present. These actions explain the weight gain, the sedation, the constipation, etc., that make the use of clozapine so unpleasant for many patients. The serotonin 5-HT2A antagonist and the 5-HT1A partial agonist actions are shown here, and we believe these may play a part in the therapeutic activity and also help mitigate some of the extrapyramidal side effect producing actions of the dopamine blockade. And this explains why clozapine is the safest antipsychotic for use in people with Parkinson's disease who develop psychosis, because these receptor interactions minimize the likelihood of the dopamine blockade aggravating the movement problems in Parkinson's disease. The next diagram shows olanzapine. This is a derivative of clozapine that was designed to avoid the problems of agranulocytosis with clozapine. It has a similar receptor antagonist profile, and this explains why it too often has significant adverse effects. However, the cholinergic muscarinic M1-4 receptor blockade minimizes extrapyramidal side effects with olanzapine. The ultra-high affinity of olanzapine for the histamine receptor means that in clinical practice, any dose of olanzapine will block all the histamine receptors in the brain, leading to sedation. The weight gain is probably due to a combination of histamine H1 and 5-HT receptor blockade. The next diagram shows risperidone, another dopamine and serotonin receptor blocker. It has the highest affinity for the serotonin 5-HT2 receptor of any drug for psychosis. And in any clinically effective dose, all these receptors in the brain will be blocked. This may add to the therapeutic activity of risperidone and partially mitigate the propensity to cause extrapyramidal side effects, but it does not prevent the elevations in prolactin caused by the dopamine D2 blockade. You can also see from the diagram that risperidone has some alpha-2 noradrenaline receptor blocking actions. As this is a presynaptic inhibitory receptor, blocking it with risperidone will disinhibit noradrenaline neurons, so increasing concentrations of noradrenaline in the synaptic cleft. This may aid the cognitive function in patients, and indeed pure alpha-2 noradrenaline receptor antagonist drugs are now being developed as possible adjunctive treatments to dopamine blocking drugs in schizophrenia. In this diagram, we look at quetiapine. We can see it's a weak dopamine D2 receptor antagonist, but its activity in psychosis is boosted by serotonin 5-HT2 and noradrenaline alpha-2 receptor antagonism, just as we've seen with risperidone. It also has a metabolite that shows significant noradrenaline reuptake inhibitory effects. And this probably explains why, in doses lower than those used for psychosis, quetiapine has antidepressant properties. In fact, it's licensed for this indication as an adjunctive treatment in some countries. At even lower doses, those used for generalized anxiety disorder, the main pharmacological effect of quetiapine is through blocking histamine H1 and noradrenaline alpha-1 receptors that lead to sedation, but also calm the anxious brain. Quetiapine can be effective in the treatment of nightmares in post-traumatic stress disorder, and this is probably mediated by the alpha-1 noradrenaline receptor blockade. In the next module, we'll look at some of the other drugs which we use in psychiatry.